Okay, I think we can start. Some people are still arriving, so my colleague Ashley and today's speakers are letting everybody in. But welcome to our 11th, I believe, 11th installment of our bi-monthly public health roundtable series on dementia caregiving. Next slide, Ashley, please. My name is Elma. I am the coordinator for the BOLD Public Health Center of Excellence on Dementia Caregiving, and I also am the coordinator for community engagement in the Center for Healthy Aging Innovation here at the center at the University of Minnesota. Next slide, please. Before we begin, we like to always ground ourselves in the land acknowledgement. We are on the ancestral homelands of the Dakota people here at the University of Minnesota Twin Cities campus. It is always important for us to acknowledge and express our gratitude to the people on whose land we live, work, and learn, whether it's in the physical or in the virtual space like today. In our work here at the university, we always strive and ensure that we give support, resources, and programs to increase access to higher education and development for American Indian students, faculty, staff, and other community members. Many of you have probably attended our past events, are familiar with our center, but just very briefly, the mission of our center is really to support public health agencies across the country in developing and growing their programming to support family dementia caregivers in their jurisdictions. We do that primarily by improving access to evidence-based programs and best practices for public health as a core component of our dissemination mission of our center. We also help facilitate connections between public health and a variety of other partner organizations and agencies serving directly and providing services and supports for family caregivers. And finally, we provide one-on-one tailored support for our BOLD public health programs and other public health departments in selecting and carrying out, implementing their strategies to support dementia caregivers. You can learn more about our center by visiting our website, bolddementiacaregiving.org, or scanning the QR code as well. Thank you. Our center is also part of a national group of partners funded called the HBI Collaborative. We are a group of partners funded through cooperative agreement with the CDC under the National Healthy Brain Initiative and the BOLD, Building Our Largest Dementia Infrastructure Act. And our collective goal is to really improve brain health for all, addressing cognitive impairment and improving supports for family caregivers, people with dementia. We really seek to integrate cognitive health into public health practice across the US. Learn more about the HBI Collaborative on our website or scanning this QR code. As you can tell, we really like QR codes. They're very practical, very quick. Next slide. And before you leave today, it's very important, your feedback. Just tell us how you like today's event, what can we improve, and what should we continue to offer. We really take your feedback very seriously, and we use it to improve our programming and for our center and all of our events. Thank you in advance. In this virtual roundtable series, this is really meant to be like a learning space and a space for building a public health community of practice. We feature the story and the work of one state at a time, and it's a space for networking, for peer learning, and idea generation. Today, we'll be hearing from our team at the New York State and their work in dementia more broadly, and specifically about in programming to support dementia caregivers. Next slide. We envision this to be an interactive, engaging space. So we have kept this in a video meeting format, to allow for conversation whenever possible. At the end of today's session, we'll have at least 10 to 15 minutes to answer all of your questions. So as you listen to today's speakers and questions come up, please submit them in the Q&A. You should have that option in your Zoom menu, and they will be answered either live or later directly by our speaker. Use the chat, on the other hand, to share comments. Because we are in this virtual space and we can't necessarily share materials or talk to one another face-to-face, use that space to share comments, resources, and information about your programs, where you work. And feel free to use the reaction buttons. And next slide, please. Before we start, we like to know who all is in the room. So we are going to just ask you to please respond to a very brief poll, which I will launch right now, just to give us an idea, and to our speakers, who all is here today. Thank you. You should be seeing the poll on your screen. Thank you for responding. I will share it shortly so you all can see as well. Thank you. I think most responses are in. You should be seeing it on your screen right now. 39% of you all are service provider in community-based organizations. 20% are bold public health agencies, and followed by non-bold public health agencies. So around a third of today's attendees are representatives and staff at public health departments. We also have people living with dementia, caregivers and community members, and a few clinical professionals. Thank you, everybody, for being here today. Today, as I mentioned, we will welcome our New York State team. We will hear from Ms. Kimberly Labarge, Lin Young, and Cassandra Zinn. I will not take up more time, and I will promptly give the mic to them. As we listen to them just today, we just wanted to draw your attention to some of the essential public health functions, services that you will hear that would be really strongly represented in their work. We will hear about their work to build a diverse and skilled workforce, improve equity and equitable access for all. We will hear how they leveraged partnerships and policy levers really to support and sustain their programming in the long term. And next slide. Here, I am going to give the mic to Ms. Kimberly. Thank you.
Thank you. Hello, everyone, and thank you for having us. As mentioned, we are the New York State Department of Health Alzheimer's Disease Program. We look forward to sharing successful public health approaches in dementia caregiving in New York State. Next slide. Throughout this presentation, we will provide an overview of the Alzheimer's Disease Caregiver Support Initiative, explain the infrastructure that has allowed New York to build Alzheimer's disease and related dementia support and services dating back to 1988, and discuss efforts to evaluate the impact of services and supports on caregivers and on systems of care. Next slide. Before we review the details of our program, it is important to understand the prevalence of Alzheimer's disease and related dementia across New York State. The information on this slide uses the Alzheimer's Association facts and figures. As you will see, 426,500 New Yorkers aged 65 and older are living with Alzheimer's disease. This accounts for 12.7% of the total population in that age group, which is higher than a typical percentage for that age group. The association recently reported that there are 10 counties in the United States with the highest prevalence of Alzheimer's disease. Bronx County in New York City is one of the 10 counties at 16.6% of the population, given its high number of older adults who are Black, African American, and Hispanic. As some of you may know, New York has a robust Medicaid program. In 2020, the cost of Medicaid to care for someone living with Alzheimer's disease was a little under $5.5 billion. This is expected to slightly increase 50% by 2025. The Alzheimer's Disease Caregiver Support Initiative services to be discussed later was of particular interest due to the cost of Medicaid users within this population. Next slide. This slide gives us a better understanding of how many people are caregiving in New York, as well as their own health conditions. As you will see, more than 500,000 New Yorkers are in a caregiving role. As we know, the demands of caregiving cause decline in a caregiver's own health. And as you'll see on the slide, over half report having a chronic health condition, a quarter report having depression, and 12% consider themselves in poor physical health. These caregivers are providing 879 million hours of unpaid care, which is equivalent to just under $19 billion in unpaid care. Next slide. Next, we will provide an overview of the racial and ethnic composition within New York State. It is important to note that individuals who are Black and African American are 2 times more as likely than individuals who are white Caucasian to have Alzheimer's disease or another form of dementia. Individuals who are Hispanic are 1.5 times more likely than white Caucasian individuals to develop dementia. Understanding these populations in New York have been crucial. According to the 2020 census, 55% of individuals residing in New York are white Caucasian. This percentage is reduced from 68% in the census back in 2010. Meanwhile, the Hispanic population has continued to increase, now representing 20% of New York's population, while individuals who are Black and African American comprise 17.5%. The New York State Health Foundation predicted that New York would be a majority minority state by 2035. Next slide. During the next portion of the presentation, we will review the history and organizational structure of the New York State Alzheimer's Disease Program. Next slide. This slide shows a timeline of the Alzheimer's Disease Program and its history. Beginning in 1985, Mario Cuomo appoints the Blue Ribbon Panel with the purpose of laying the framework and direction for New York State. In 1988, legislation created the Alzheimer's Disease Assistance Centers, now referred to as the Centers of Excellence for Alzheimer's Disease. In 1990, funding was established for the Alzheimer's Disease Community Service Programs. In 2007, there was the creation of the New York State Coordinating Council, otherwise as we'll refer to it, known as the Council. In 2008, Community Assistance Program was modified to ensure statewide effort. In 2009, the Council released their first report establishing a strategic plan for Alzheimer's disease and supports and services. And in 2015, New York received a landmark $25 million. Later in our presentation, we will be discussing further in detail how these funds were allocated, along with successes and lessons learned. As you can see on the slide, New York has been doing this work for a long time, and we continue to advocate for these critical services to remain in place. Next slide. We understand some of the audience today, and from the poll earlier, a lot of you may be bold awardees working on their infrastructure. So we thought it would be helpful to share where the Alzheimer's Disease Program sits. The Alzheimer's Disease Program in New York State is currently positioned in the Department of Health. It is important to note, New York's Department of Health is a large entity made up of many programs. The Alzheimer's Disease Program is one of them. The Council provides strategic guidance for services related to Alzheimer's disease and related dementia, and we'll be covering that more in detail in the next slide. Next slide. As mentioned earlier, the Council was established in statute back in 2007. The Council is a big part of what we refer in New York State as our coalition. The Council assists with interagency planning and policy specific to cognitive health. There are 21 members who meet quarterly and produce a biannual report with recommendations to the governor and legislature. The Council drives the New York State strategic plan and seeks to facilitate agencies working together and collaboratively. As you'll see on the slide, leadership on the Council, there's representation both from the New York State Department of Health as well as the New York State Office for Aging. Next slide. Now we will discuss further in detail what New York did when the state was allocated $25 million back in 2015. In 2015, the Alzheimer's Caregiver Support Initiative was established. The initiative was based on an evidence-based replication of Mary Middleman's work in 2006. New York sought to establish an array of services, starting with expanding the already existing Alzheimer's Disease Assistance Centers, ADACs, which were rebranded to the Centers of Excellence to support early detection and diagnosis, then ensuring there are evidence-based services in the communities at a local level to support caregiver needs. Next slide. Next slide. First, New York established regions and released a request for applications, RFA, to solicit local providers and champions in those prospective regions to serve as boots on the ground. These were providers who knew their regions and the populations they serve best. These contractors do the work of the department at a local level. This map shows 8 Caregiver Support Initiative regions and 4 subregions of New York City. For the Regional Caregiver Support Initiative, New York City was divided into smaller subregions, and we have a contractor for each subregion. When speaking about New York State, a lot of people automatically think that we live in New York City, an urban area. The areas, as you'll see on the map, the areas from the dark green and below do represent downstate New York City urban areas. However, most of the map, the dark green area and above, represent upstate regions of New York, which are made up of rural communities and at times shortage areas. Next slide. The initiative was created to include both community support and education, as well as diagnostics and professional training. Through the community support and education, the intention was to enhance the quality of life for individuals living with the disease, as well as their caregivers, and also to decrease caregiver burden. For diagnostics and professional training, it was intended to maximize medical treatment and advanced care planning. As a lot of you attendees today recognize, an early and accurate diagnosis allows for the determination of and respect for the patient's treatment preferences and financial wishes. For caregiver support and education, we initially established 3 initiatives, as you'll see on the slide. We will discuss these programs in greater detail later on in the presentation. We thought it would be helpful today for us to share our experience with the Caregiver Support Initiative underserved communities, which you'll notice on the slide as highlighted. We did not continue this into our current round of grants, and we thought it might be helpful to share with you today why that was. In 2015, we funded 15 programs across New York State, with 7 in New York City, that proposed to reach a targeted underserved population in their communities. Programs supported specialized outreach and programming for isolated rural poor, LGBTQ+ individuals, individuals who are Black African American, and individuals who are Hispanic. Each program received $100,000 per year for a 5-year contract term. These contracts and programs ended in 2021. As it happened, these programs were not as effective as we hoped initially, and we wanted to share some of the reasons why that was. Funding was not sufficient to support salaries and activities needed to establish the relationships and trust needed to effectively reach their targeted populations. And 5 years did not seem to be long enough for these relationships to foster. Some of these challenges to the success of the underserved initiatives tended to stem from caregivers who did not identify as such, cultural stigma and isolation, language barriers, reliance on family rather than accepting formal outside services, geography and hard to reach areas of the state, and again, just to emphasize that trust component was key. The underserved programs struggle to operate as a standalone program and were most successful if embedded in a larger organizational effort. We use this experience to build underserved requirements into the Regional Caregiver Support Initiative programs, new contracts that began in 2022. Cassandra will be going into greater detail about this program later on in the presentation. Next slide. The Alzheimer's Disease Caregiver Support Initiative goals were based on evidence and practice that providing an array of caregiver services achieves the following. It delays nursing home placement, improves the health and quality of care, both for individuals living with the disease and their caregivers. It helps avoid unnecessary hospitalizations and emergency department visits. It increases the ability to maintain individuals living with the disease in the community, and it supports dementia-friendly communities. The goal continues to expand the safety net for caregivers of individuals living with the disease by recognizing and addressing the need for caregiver support services and addressing caregiver stress. Much of our evaluation is based on these goals, and Lynn will be discussing that more towards the end of our presentation. Next slide. Contractors within New York State, the Alzheimer's Disease Caregiver Support Initiative, are required to meet the priorities that you'll see on this slide, starting with promoting the importance of early detection and diagnosis, which is primarily a deliverable for our Centers of Excellence for Alzheimer's Disease and Related Dementia, but all Alzheimer's Caregiver Support Initiative programs and contractors are positioned for the following activities. These include educating the public regarding risk reduction strategies, encouraging conversations with primary care providers about changes in cognition, training providers about the importance of initiating conversations about cognition, increasing awareness among community gatekeepers and recognizing individuals at risk. Secondly, you'll notice a priority of person-centered care planning. We want to ensure that individuals have access to care plans that are person-centered and appropriate to the current need. We want to respect and value the caregiver and the individual living with the disease. We want to adapt and provide options as these needs change. And we want to provide support in a way that improves overall well-being. And the third priority, creating linkages to community-based services. Once someone is newly diagnosed, we want to make sure to get them linked to services to support their diagnosis and connecting them with community-based support. We want to inform individuals living with the disease about services that are available to them in their immediate region or community. We want to recommend and refer to appropriate services as their care needs change. We also would like to enhance caregiver knowledge about the disease process and how to navigate these service options. It is also important to educate and provide strategies for managing the disease progression. And next, I will pass it over to Cassandra.
All right. Thank you, Kim. Now that we have gone over the history of our program, along with the demographics of those we serve, I will be highlighting the current program components. Next slide, please. The Centers of Excellence for Alzheimer's Disease, as mentioned, were originally called the Alzheimer's Disease Assistance Centers, and many times we refer to them simply as CADs. And these 10 Centers for Excellence are all considered as the experts of their region and are spread out regionally across the state to ensure access to diagnostic support and other appropriate services. They work statewide to increase public awareness, spread information and access to clinical trials, and they collaborate with other Alzheimer's disease program contractors. The Centers of Excellence also consist of a multidisciplinary team working to meet their deliverables, again, such as increasing diagnoses, early detection, early treatment, and community awareness. They also work to expand the workforce. They expand community education, providing trainings to medical and health professionals, and so much more. Next slide, please. The Alzheimer's Disease Community Assistance Program, or as we call ALSCAP, is a statewide effort in which we contract with the Coalition of New York State Alzheimer's Association chapters. Here in New York, we are fortunate to have 7 chapters for the Alzheimer's Association that coordinate deliverables statewide. This program was written into New York State public health law to tackle Alzheimer's disease and related dementia by promoting public awareness. And some of the key services included in this are care consultations, education, training, a 24-hour helpline, which has the capability to serve people who speak over 200 languages, outreach and training of important constituencies, such as first responders, faith-based leaders, long-term care facilities, and more. And newly added to this contract cycle is outreach and engagement with underserved communities. Next slide, please. The Regional Caregiver Support Initiative uses evidence-based and evidence-informed strategies to provide core services to every county in New York State. And while ALSCAP is more bigger picture with community-based supports as the foundation, the Regional Caregiver Support Initiative is a little more boots on the ground. This initiative aims to provide one-on-one services to caregivers and individuals to increase support, improve health equity, quality of life, and relieve some of that caregiver burden. The initiative is comprised of contractors who are chosen as the experts of their region and are best suited to serve the populations in those counties. Some of the services in this initiative include outreach and engagement with underserved individuals, respite services, joint enrichment activities, which may include things such as art classes, musical performances, and more, caregiver support, engagement, and more. Next slide. And with that, I will pass you on to Lynn.
Thank you. I'm pleased to round out our discussion today by talking about our program monitoring and evaluation efforts in New York. First slide, please. As you've heard, in 2015, New York State almost overnight went from operating as a $1 million program to a $25 million program. I've had many states ask how we were successful in obtaining that funding, and that funding came about from strong advocacy from our community partners as well as the association here in New York. And we had a strategic plan in place through our council that required funding, and someone got someone's ear, and before we knew it, we had the 25 million. Once we had that new funding, it gave us an opportunity to think creatively about how we wanted to get that money out to the local level. And as a result of that funding, we established the Caregiver Support Initiative, using the vast amount of evidence that was out there demonstrating that supports for caregivers could reduce burden and could support much better outcomes for both the caregiver and the care recipient. So we hope to contribute to that body of evidence, and we were fortunate at the time to partner with the University of New York at Albany School of Public Health to initiate a formal evaluation of our Caregiver Support Initiative. The evaluation effort was aimed at tracking the program implementation and the services we provided, monitoring the impact of these efforts, allowing us to modify the programming in future years, as you heard that we did with the underserved project, as our funding continued, and to demonstrate that our work was both translatable but also replicable. The evaluation effort encompassed the first 5 years of our funding, from 2016 to 2022. I just want to note that was the first round of our grant cycles. Those grants were extended because of COVID. And then post-COVID, we were able to do a new RFA. And as Kim referenced, we have a new round of grant providers who are under contracts with us through 2027. The evaluation plan took a multi-pronged approach. First of all, the Caregiver Support Initiative, 36 contractors that we were working with that included the Centers of Excellence, the ALSCAP program, and all of our Caregiver Support Initiative programs, were required to submit quarterly reports. And those quarterly reports included a qualitative narrative, providing us information with how they were meeting their program goals, the types of activities that were being delivered in their local communities, where efforts had been particularly successful, and any barriers encountered along the way. They also submitted a quantitative dashboard report that gave us data about the amounts of services being provided and the numbers of individuals reached. Secondly, CSI participants were asked to complete a demographic data form voluntarily, but that data, that provided us with data with approximately 25,000 caregivers each year of the study. And thirdly, and I'm going to highlight some of this today, the School of Public Health conducted topic-focused surveys with Caregiver Support Initiative participants, including one specific to caregivers, which again, I'm going to talk a little bit about today. Next slide, please. So New York State was not new to the BRFSS, but we strengthened our use as part of our evaluation plan and by integrating the subjective caregiver and cognitive decline modules into those evaluation efforts. We produced a data brief after the last completed survey in 2018, and Kim is putting that link in the chat so that you are able to access that on the Department of Health website. Next slide, please. Our evaluation of service data showed and verified that we, during the first grant cycle, we provided an enormous array of services. More than 61,000 diagnostic assessments were completed to address concerns of individuals either suspected of or reporting cognitive decline. And beyond that assessment, we ensured that people were connected to service providers by nearly 20,000 referrals to community providers. Training sessions, primarily the responsibility of our Centers of Excellence, training sessions targeted and reached more than 100,000 physicians, healthcare providers, and students about the topics of early detection, diagnosis, treatment, and care management of individuals living with Alzheimer's disease or a related dementia. A strong number of care consultations, support group sessions, and caregiver education opportunities were also made available to caregivers. And we were very proud of the fact that more than 750,000 hours of respite care were delivered under our program. Next slide, please. Next slide. Okay, thanks. This slide just reflects an overview of the caregivers that were served through our Caregiver Support Initiative. Compared to a national sample from the AARP, we felt that our caregivers were tended to be older. They were more likely to be female than the national sample. They were likely to be a spouse, but even more likely to be an adult child. And they were slightly more likely to be in the lower income categories, but not eligible necessarily at a Medicaid level. Importantly, we reached caregivers in all 62 counties of New York, supporting our intent to try and create a statewide effort. We had particular interest in our rural underserved areas, the regions upstate, as Kim pointed out in the regional map. We found that we were successful in reaching rural areas with about 25% of recipients coming from less populated areas of New York. We noticed that rural caregivers were more likely to use support groups, educational sessions, joint enrichment activities, and respite than their counterparts in more urban areas. We also found that, interestingly, rural caregivers were also likely to try different services, but they weren't necessarily likely to return. So we thought that we would like to hear some chat. Next slide, please. So we are wondering if people have found particular patterns in other states regarding rural caregivers and accessing services in rural areas. So if people would like to I'll give just a few minutes for people to type into the chat. We would love to hear a little chat about that.
Hi, Lynn. I think there are a few responses in the chat. I see you're talking. I don't know. You're
Yeah.
still.
Yeah, sorry. So what I am seeing in the chat may be different than what you're seeing. So in West Virginia, we have care hubs that folks have to travel to, which is difficult for caregivers without paid time off. Many of our jobs, please note this is from Ontario, Canada. And we do find that as well, that, caregivers being able to access services in the more rural areas where there isn't public transportation is an issue. And we think that may be why people aren't necessarily willing to come to repeat sessions. And there's a couple questions in the question and answer that we will leave till the end, if that's possible. Yes, and someone is raising the issue about driving 2 hours and wait list for neurologists 8 months. We are experiencing the same issue with our centers of excellence, with extended wait times, and we are trying to consider that now as we move forward. We are finding 6 to 8 month waits for people to get seen at a center of excellence, where the assessment is, integrated. It's interdisciplinary. It's much more of a detailed assessment. It's really a great resource for each of the resources, but the availability of slots for those diagnostic procedures is really a concern for us. And accessing knowledgeable physicians and medical professionals is very hard and frustrating. Yes, the whole workforce shortage issue is something also that we've asked our centers of excellence to address in their training efforts. And through our BOLD funding, our new BOLD funding, we will be targeting the whole issue of diagnostic, detection and diagnosis as well. Okay, so I'm going to move ahead. Next slide, please. Thank you for the comments, and hopefully we can answer more during the questions and answers. So I want to take just I want to transition to one of our focused surveys and just touch on a little bit of a detail of, what we learned from that survey. In 2019, which was year 3 of our Caregiver Support Initiative, our evaluators conducted a targeted caregiver survey focused on evaluating how caregivers perceived benefits from their participation in our program. It was emailed to 22,000 caregivers, and we had about 2,000 caregivers respond, which we felt was pretty good. Next slide, please. Caregivers were asked how much they agreed with 13 specific benefits that are identified in this graphic. Just to summarize, more than half of the respondents were able to report at least 8 different benefits from their participation in Alzheimer's and caregiver support services. The most commonly mentioned benefit related to improved knowledge and skill about the diagnosis and about Alzheimer's disease and dementia overall, about caregiver and dementia-related resources and supports, and about the caregiving role and the skills important to be successful in that caregiving role. Next slide, please. We also examined the relationship between the service use and the perceived benefits. Those caregivers using more services and different types of services, which is displayed on the horizontal axis, tended to report a higher number of benefits overall. Increases in perceived benefits were significantly associated with the number of different services that a caregiver participated in, the duration of their service use, and the greater levels of participation. Regarding services specifically, the use of respite and joint enrichment activities were shown to correlate pretty strongly with an increased number of perceived benefits. Next slide. It's well known that high caregiver burden is associated with a broad array of negative outcomes for both caregivers and the care recipient. These outcomes include higher levels of depression, physical illness, a decreased quality of life, and potentially an earlier move towards nursing home placement. So our caregiver survey explored caregiver burden and whether burden levels were impacted by service use. We used the short 4-item Zaret burden interview to assess burden. We asked caregivers to both report their level of burden currently while they were accessing services, as well as their perceived burden before services were begun. Survey data supported our belief that the comprehensive array of services and supports that we had put together, delivered at a community-based level, reduced the perceived caregiver burden when compared to their thinking back before services. Next slide, please. For the sake of time, I'm not going to spend too much time on the graph to the right, but I do want to say that caregivers who used Caregiver Support Initiative core services, and just as a reminder, that includes care consultation, respite, wellness activities, support groups, educational sessions, and joint enrichment activities, had a significant burden change to report as compared to caregivers who did not use the services. The impact on burden was particularly notable for caregivers using respite, caregiver wellness, and those who participated in caregiver education sessions. Next slide, please. So as we noted earlier, one of our founding goals for the Caregiver Support Initiative was, based on Mary Middleman's work, was to delay nursing home placement, and ultimately we hope to impact the overall cost of long-term care in New York State. We asked our caregivers whether they felt that the initiative delayed nursing home placement. Of the 2,000 caregivers who responded to the survey, more than half of the respondents felt that services definitely or probably allowed them to delay nursing home placement for their care recipient. Next slide, please. We then asked those caregivers who responded definitely yes or probably yes to estimate how much longer they were able to keep their care recipient home. 50% felt that the delay was more than a year, and we were pleased to see that almost 40% of our cohort felt that their time was greater than 18 months, and that correlated nicely with Dr. Middleman's work for sure. Next slide, please. So being able to estimate cost savings to New York State was a little more challenging for us, and to be honest, we attempted a number of different strategies. Ultimately, we wanted to support that the state's investment of $25 million in Alzheimer's disease services resulted in a cost savings for long-term care. overall, what we noted from our survey participants was that participants tended to participate over, the people who responded to the survey tended to participate to a greater number in services. Those caregivers who felt that the Caregiver Support Initiative services allowed them to delay placement of their care recipient were even higher users. So we determined a benchmark for those participants using more than 3 different services or 8 total service sessions as being those individuals most likely to delay nursing home placement. We applied that benchmark to the number of Caregiver Support Initiative participants that we had served, and 14% of that population met that benchmark. So we applied 14% of our participants, close to 15,000 individuals, to an average annual cost for nursing home care to Medicaid in New York of $140,000, and applied a 1-year delay in placement. So our evaluation projected more than $2 billion in savings to nursing home costs in New York. In light of the $25 million investment that New York made in this initiative, we have been able to report about $18 in savings for each dollar spent on the initiative. Next slide, please. So the report that I just touched on was primarily the report number 2, which is the effects of caregiver health and well-being. But all of the final reports from that initial evaluation period are posted on the New York State Department of Health website on our Alzheimer's disease program page. Kim is putting the link in the chat, so you have it, but you'll have these links as well. But all of these reports are available, both the evaluation reports from year 1 and the special topic focused reports as well. Next slide. We also invite you to look at the Alzheimer's Disease Program website in New York. It's a relatively interactive website so that any consumer in New York can click on the county they live in, and a list of those programs that are funded under our initiative will come up as resources. The site also has a variety of other links to other resources, both within the state and also nationally. And again, those reports that we've been referring to are there as well. Slide. Thank you, and we will open the time up for questions.
Thank you so much, Lynn, Kimberly, and Cassandra. This was an amazing overview. It's really impressive, the infrastructure you have built and the ecosystem really for dementia you've built in the New York State. So there are quite a few questions in the Q&A and in the chat. So I will just try to organize them a little bit by topic. The first one that came in, I would say maybe Kimberly, they might be for you. They came in when you were talking about the Caregiver Support Initiative for underserved communities. Yep. Ms. Johnson Florence was asking, how was recruitment completed? I assume in such work, it is always stated that researchers are unable to find Black participants. In this case, we're talking about partnerships and selecting organizations who serve these communities. How were they selected? Perhaps could you speak a little bit about that?
Yeah, I bet. I'm going to take that question because I'm the local historian, having been here a while. So when we've used the same RFA procurement process for the Caregiver Support Initiatives for Underserved Community grants. We felt that providers in their community knew their populations the best and could propose for us the strongest programs to be funded. And indeed they did. So we had a lot of very small local agencies who were, they were involved in some dementia care, but not on a big scale. And they had a great idea to serve those populations that they were having a hard time reaching. So based on an RFA application, we selected 15 awardees. And as Kim mentioned, we deliberately wanted 7 in New York City because of the high population of underserved there. What we found, was that the programs were great. They didn't have enough money to really make the impact that they hoped to, and they also didn't have enough time really to build the trust. They worked hard to make their program work, but it wasn't as successful as we had originally hoped. So we dialed that back, and when we did our next procurement, as we mentioned, when we solicited for the new regional caregiver support initiative programs, we integrated a pretty strong component into their award. A certain percentage of their funding has to be used for underserved initiatives, and they're reporting that on a quarterly basis.
Thank you. And a related question here, Lynn, is also, what has been your success in reaching Native American populations on and off reservations? Could you speak a little bit about that?
Yeah, that's a great question, and I'll let Kim or Cassandra jump in as well, but that's a great question. And we have had mixed success. We've tried to target their public health agencies within the community as a way to partner with them. Again, building that trust has been really challenging. We had one of our centers of excellence who actually hired someone from one of the communities, and that was one way that we're able to infiltrate. But it really has been a remaining struggle. I mean, I think we could have a whole topic on that discussion on how best to help those communities and how to build that trust.
I just wanted to add one piece. I think what we've heard from our contractors is that it takes so much time. As Lynn mentioned, it could take upwards of years, and just being very cautious not to come in with your own agenda and really listen to the needs of that community specifically and tailoring to the needs. It may not be what the outcome that you came in with, but as long as you start there. But we have heard it can take upwards of years to build that trust.
Yeah.
And I will say too that we have shared with our contractors much of the information that was shared by one of your presentations early on about targeting underserved populations. It was a wonderful resource, and we required all of our contractors to watch that broadcast. So that was helpful.
Great. I'm glad to hear that it was helpful. The next question is related to the tools used for, I believe, caregiver assessment. This might have been a question for Cassandra as you were speaking about the program, but anybody really can answer. What comprised a diagnostic assessment? And then, yeah, there's another one, but I'll let you answer that one first.
So all of the centers of excellence, as part of their RFA, as part of their application, they were required to follow the evidence-based assessment that was promoted, I forget the year, by the association and NIH. So I can say almost across the centers, everyone gets a complete physical assessment. They do include imaging and most likely biomarker testing. They will have, all of the teams have either are neurology led or geriatrics led, but they have the other discipline available. Most of them have neuropsychology for those people who need neuropsych as more of a differential diagnosis. And then every program either has a social worker or a nurse care manager who can then help the person, once they have the diagnosis, help that person navigate to services, to what they need now and what they might need in the future. But starting to get the dyad thinking about the continuum of services that they might need as they progress the journey.
Okay, thank you. And another related question. Did you use a specific evidence-based care consultation program?
Ooh.
And how was it delivered?
We did not direct the care consultation format. Kim, what were you?
I would say that each program, I think some of the programs incorporated our demographic form and information, but then added on based on their specific program and population to gather the critical information that would be needed in order to guide the care plan. So I think it varies amongst programs. I know that's not a direct answer.
No. And the Alzheimer's Community Assistance Program, as we mentioned, is comprised of we have 7 Alzheimer's Association chapters in New York. So, they already had a format for care consultation that I think that they engaged.
Right.
So
That's correct.
that's correct.
There's so much work you're doing in New York, and it's hard to prioritize all these comments and questions. I'm just trying to group them. I would like to be able to ask all of them. So I'm just going to take one more. It's related to policy, and hopefully if we have time to the coalition. Does one from Ms. Cockrell, Tarisha, does the New York Alzheimer's Council meetings have any efforts towards retaining caregivers in the workforce? FMLA amendments, this is more of that interest for public health and kind of policy direction and guidance to support working caregivers. What is New York doing in that space?
That's a big question. I think New York, like other states, is, the whole issue of workforce is very complex. We did a small study within our Caregiver Support Initiative, working with the School of Public Health, but also the State University of New York School of Public Health has a center. I just sent a Center for Workforce. What was it? They have a Center for Workforce Studies, and they do a very comprehensive work on looking at workforce shortages and how some strategies that can be addressed. They just released one report on nursing in acute care. It's not always related to Alzheimer's care specifically, but I know that New York is really seriously looking at the whole workforce shortage, because we have shortages across New York, and as we've alluded to, New York is so diverse that sometimes there are not perceived shortages of some workforce categories in New York City, but that are significantly a significant concern as workforce shortages upstate. So not only do we have to look at workforce, we have to look at it at various levels of the state. And we do know, we're just like every other state, we're struggling with a number of neurologists. We have 2 very active geriatric psychiatry programs in New York that generate most of the geriatric psychiatrists, and they're not able to generate enough. So those are serious issues for dementia care.
Yeah. Well, we are.
I wanted to touch too. I saw Sarah McGee made a comment about the day programs, and I want to say that New York State also struggles with the same. So they're not alone in that as well.
Good. Well, there sure are more questions that I would love to ask, and I see one of our attendees also has their hand up, but we are unfortunately at time. We wanted to shorten these sessions from being 90 minutes to 60, really in recognition that we all of our busy schedules and trying to keep this short, but provide as much content and share as much as we can. Thank you for being here today. We will be sending a link to the recording along with the slides and today's presentation and notes and resources shared in the chat with everyone. So you will get that information. And please, again, thank you for being here. Let us know how we did, what we can do better as we plan more roundtables like these. Thank you again. Thank you. Big thank you to our Team New York team today for being here with us and for sharing about it.
Thank you for inviting us. We love sharing our story.
You are welcome. Thank you, everybody. And we hope to see you at the next roundtable in a couple of months. Have a good day.